getting ready to put my presentation together for you, and I wanted to make sure I understood the new Affordable Care Act. And I was kind of caught in this one section here, and I wondered maybe you could help me understand it. It's under a section called Increased FMAP for Medical Assistance for Newly Eligible Mandatory Individuals. And I'm down in subparagraph 2A called Newly Eligible. Maybe you can help me understand this. Newly eligible. The term newly eligible means with respect to an individual described in subclause 8 of section 1902A10A1, or is that I, an individual who is not under 19 years of age or such higher age as the state may have elected, and who as of December 1st, 2009 is not eligible under the state plan or under a waiver of the plan for full benefits or for benchmark coverage described in subparagraph A, B, or C of section 1937B1, or benchmark equivalent coverage described in section 1937B2 that has an aggregate actuarial value that is at least actuarially equivalent to benchmark coverage described in subparagraph A, B, or C of section 1937B1, or is eligible but not enrolled or is on a waiting list for such benefits or coverage through a waiver under the plan that has a capped or limited enrollment that is full.
Good evening, everybody. How you doing? It's great to be up here in northwestern Minnesota. I was born and raised in St. Paul and traveled extensively to speak across the country, and it's always best to be here and speak with people whose language I can understand. Eh? Yeah. No, it's great to be here, and I'm really glad you all came. We always worry that nobody will show up, and we're glad that you all did. We're going to talk a bit tonight about the Affordable Care Act, the Act of 2010 passed by Congress that revolutionizes the way that America consumes health care, or will revolutionize it. You could say that making of the Affordable Care Act was a little bit like this, putting a wall up and then setting a target on it and saying, let's see what sticks. Let's try this idea. Let's try that idea. Let's throw this at it. No, there's one that actually sort of almost hits the middle. And I remember when I created this graphic the first time, and I thought, this is really kind of fun, you know. And then I heard one of the authors of the Affordable Care Act, a fellow named Jonathan Gruber, say on an interview that, well, we put a lot of ideas into the Affordable Care Act. A lot of them are experimental. We really don't know what's going to work or not. And I thought, well, what an interesting way to make a law that's revolutionizing the country that spends $2.7 trillion remaking our entire healthcare system. Let's just put a lot of stuff up there and see what sticks. But as Kathleen Sebelius might say, that's close enough for government work. On December 24th, 2009, we were given this Christmas present when the Senate voted 60-39 to pass the Affordable Care Act. You might remember that the 60th vote came from our own Al Franken. Al Franken had not won the election as far as we knew, but then he won the election after the recount, and he was the 60th vote. It is arguable to say that had that not happened, there would not have been an Affordable Care Act as we know it. Then on March 21st, 2010, Congress passed the Affordable Care Act again. The House passed the bill. It was very interesting how they did that. Some people question it constitutionally because all appropriation bills have to originate in the House. That's according to the Constitution. Well, the Senate found a way around that because the House had passed an appropriation bill the summer before, and the Senate simply took that bill, did what they call a strike everything amendment, took the language out and put the language of the Affordable Care Act in it and said it had originated in the House. That's the way that politicians get their work done. And so that bill passed in the House. 10 days later it had to be amended because of imperfections in the bill that the House would not agree to, and that was the creation of this bill that Nancy Pelosi, the Speaker of the House, said soon after, we have to pass the bill so that you can find out what's in it. And of course, that was a remarkable statement to make, a very candid and honest statement, if you will. And we have been discovering what's in the bill. It's quite fascinating. Here was one example, something you can really chew on. Some of you are just now getting your big burger. Well, here, this is actually a provision from the Affordable Care Act. It's Section 4205. I know I'm staying in the way of some of you. I can't help that, I'm sorry. I can move back here, though. And this is actually the wording right from the bill. It says the Secretary will, the Secretary is the Federal Secretary of Health and Human Services, will consider standardization of recipes and methods of preparation, reasonable variation in serving size and formulation of menu items, space on menus and menu boards, inadvertent human error, training of food service workers, variations in ingredients, and other factors as the Secretary determines. In other words, the Affordable Care Act gave the Secretary of Health and Human Services in Washington, D.C. the power to regulate the menus of the restaurants in which we eat across the country. And this was a response to the obesity epidemic in the country. Some of us thought it was better if individuals took the initiative to lose weight and quit eating that kind of food rather than having the Secretary design the menus. We think someday there might be a warning on food similar as that we had on cigarettes, you know, warning eating food may be hazardous to your health, signed by the Secretary. Well, I only use that as an example to show you some of the degree to which the bill does micromanage individual behavior. And the more of that there was in the bill, the more confusing it became. Those words that I read to you are literally from the bill. I chose them at random, okay? That's 2 paragraphs, by the way. If you thought that was a whole bunch, it's just 2 paragraphs. It's very, very hard to understand. Now, I have a question for you, because in this room, people have opinions about what healthcare ought to be about, and if we're going to reform it, what really makes the most difference, what's most important. Is access to healthcare services the primary thing we should be looking at when we reform, you know, one of the most important services there is in the country? Should we focus on the ability for all individuals to get access to all the care they want at the time they need it? Should that be the first priority? Or should the priority be the quality of those health services? Should we focus on improving the quality of services, not so much access? And here's the problem. I forgot to blow up my balloon. When you look at healthcare, it's a little bit like a balloon. You squeeze one thing to increase access, and it blows up another part, maybe expense and cost, and so then you squeeze that part, and maybe the quality of service falls, and then when you squeeze that part, the whole thing blows up, which usually I do, and everybody yells at me for being noisy. The third one would be maybe reducing the number of uninsured. Maybe that should be the priority of healthcare reform if we can't do all of them, or affordable health insurance. Perhaps that should be the focus. So there are other things that we should consider when we're talking about health care, but maybe these were the 4 primary things that people looked at. And I might ask you, in your own mind, your own heart, you know, what's more important to you? And you know what? It is different at different ages. Access to health care services, of course, is primary for people who really have a need right now. It's not as important for people who pay high insurance and are pretty doggone healthy and hope they never have to use it. So these priorities change and they move around. The Affordable Care Act, however, did choose one of these to be the primary motivation for writing reform legislation. And the one it chose was affordable health insurance. The feeling became, if we can reduce the uninsured rate to 0 and create affordable health insurance to do that, that we will solve some of the other problems. I thought that perhaps the primary thing should have been reducing the cost of a unit of health care. That if we could focus on ways to actually reduce the cost of health care, then we could also increase access, we could increase quality, we could reduce the number of uninsured and so forth. But that isn't how the bill was structured. It was really structured to reduce the uninsured rate to 0 by reducing the price of health insurance. So what is the best way to achieve all 4? This is the debate we're in right now in the political season that we're in. Is the debate to increase the government role in order to increase access, increase cost, or not cost, increase access, improve quality, reduce cost, or reduce the uninsured? Or would it be better to release private market incentives that would cause these things to happen? Or is it a combination of both? Now, it just happens to be that healthcare is probably the most regulated industry there is. The second most regulated is probably insurance, and no doubt health insurance, highly regulated industries. And so the Affordable Care Act now has added more layers of regulation to this. I want to step back in time just a little bit for a history lesson. Some of you are obviously old enough to have been around in this era. I was born in 1947. I get my Medicare card this Saturday. Does that tell you anything about my age? I grew up in the 50s. I am in the second year of the baby boomers. There are 78 million of us now coming into the Medicare system. We're going to bankrupt it. We do have to fix this system. Back in the 50s, when I was a kid, I would get up in the morning and I would say, gee, Mom, I know it's Tuesday and I'm supposed to go to school, but my stomach is upset and I think I need to stay home. And my mother would do this remarkable thing. She'd pull out a thermometer and she would put it in my mouth and she would say, you don't have a temperature. Yeah, but Mom, you know. Well, sometimes I could get away with it because I really didn't feel good. And she would send me to bed. And she'd have a big plastic bucket there for me just in case something happened. You know how that is. And then the next day, Mom would do it again. And if I still felt bad, she'd say, maybe let's try this again. And the third day, she might call Dr. Loken. And Dr. Loken, who brought me into the world, then would drive over to the house for $3. He'd, you know, check me out and say, he's got the flu. This'll pass. This was typical health care in the days before the modern healthcare system that we have today. Patients were viewed as consumers, but they were in charge of their own healthcare dollars. In fact, they paid the first dollar for their healthcare. My dad used to keep a shoebox, and he would add up the receipts. And if he ever hit his deductible, his really high deductible, which I think was $50, then he could get reimbursed by the insurance company. And there was a few times he did. My mom had some surgeries and so forth, and they used their health coverage. And you know what? They had 5 children. They got through the 50s and 60s really quite well as somewhat healthy. The kids were somewhat healthy. When there was an issue, they got the health care they needed. During that era, doctors and hospitals had a remarkable responsibility. Their responsibility was to provide care. That's what they did. The healthcare payers were called insurance companies, and they paid claims. Today, they're no longer insurance companies. They're now called health companies. And their job is to get out ahead and try to keep you healthy so you'll never get sick so they never have to pay a claim. They don't look at themselves as insurance companies anymore. Back in that day, 48%, in fact, this is 1960, 48% of health care was paid out of pocket. Individuals paid that much of their own health care. What was average life expectancy? 65, 66 years of age. Air conditioning was becoming more common. The highways were being improved. We had flash frozen food that was a little healthier than some of the stuff we were used to before. There was a lot of things going on in the world. We talk a lot about life expectancy now and all the things that affect it. I thought it was fascinating. I was in Costa Rica. And Costa Rica has a life expectancy a couple of months longer than ours. Not a lot more, but a couple of months longer. And I saw a presentation there, and they showed how they had an average life expectancies in the 30s. And then all of a sudden, this miracle came along, and within like a decade, they went up to 70 years old or 72 years old. You know what the miracle was? DDT. It had nothing to do with healthcare. It had to do with killing mosquitoes and stopping malaria. And so now their health care happens to be, their life expectancy happens to be about the same as ours. According to United Nations, in 2000, their health care is better than ours because they live 2 months longer than we do. It's quite amazing how those things are done.